welcome to lecture number 4, Dental Radiography. I'm going to forewarn you before we get into it that this is a very long lecture, one of the longest lectures actually in the whole series. And that's because to become accredited in your state, or for you to be able to actually take x-rays, we do have to complete a pretty thorough, in-depth examination of everything that's related to radiography. So here we go, stay with me. So lecture number 4. Radiography is applying the basic science of physics and chemistry as they relate to photography. So what is a dental radiograph, otherwise known as an x-ray? It's the representation of a three-dimensional object used in dentistry to study and identify structures that are not visible to the naked eye. The history of the radiograph is from a German physicist named Wilhelm Conrad Röntgen, and it was discovered in 1895. The first dental radiograph was made by Otto Walkhoff as he experimented on himself actually in 1896. There was other practitioners and dentists that actually also practiced with dental radiographs in order to perfect what we now use as dental x-rays. The first x-ray tube was invented in 1913 by William Coolidge. So the x-ray machine, it consists of a control panel, an extension arm, a tube head, and an x-ray tube. It's the x-ray tube that is responsible for actually generating those x-rays, and it is contained within that tube head. Types of x-ray radiation are ionizing radiation, primary radiation, remnant, secondary, scattered, and stray radiation. Ionizing radiation is the radiation that actually produces those x-rays, and it's produced when ions pass through the matter. Primary radiation is also known as the direct or primary beam. This radiation emerges from that x-ray tube and it penetrates depending on the kVp or kilovoltage peak and the MA or milliampere settings. These are all settings that you'll have on your actual control panel, and your doctor will help you know which ones to use. Comparative units of radiation measurements are radiation exposure, or the amount of radiation a person is exposed to. That's a good one to know, is how much exposure or radiation a person is exposed to. The absorbed dose is the amount of energy that's absorbed by the tissues. The dose equivalence is the measurement used to compare biological effects of different types of radiation on the tissues of the body. And the maximum permissible dose, or MPD, is the measurement that represents the exposure limits for individuals who are exposed during work to radiation. That amount of radiation to the entire body actually produces a negligible chance of harm or injury. The ALARA concept is the concept that contains the exposure to radiation must be kept as low as reasonably achievable. All methods of reducing radiation exposure should be exercised. So, because you will be in a job that actually has you exposed to radiographs, these radiation exposure limits are applicable to you, and we'll kind of get into how do we protect ourselves from these radiation exposures. So radiation protection first for the patient is during pregnancy, x-ray protocols for pregnant patients should be established and closely followed. Many experts suggest that patients should refrain from having dental x-rays during pregnancies, while other OBGYNs suggest that only taking x-rays on an emergency basis would be in the second or third trimester and would be considered safe. Using lead shields is also very important, and these lead aprons should be 0.25 to 1.25 millimeters in thickness, and the goal is to protect the thyroid and reproductive organs of patients. We also like to use positioning devices and film holders while taking images. These devices decrease the need for retakes and eliminates the need to have the patient use their finger to try to help hold that x-ray into the place. Also, the use of fast film, which is e-speed film, it cuts in half the exposure a patient may get. Now, please recognize that fast film is considered traditional film, and that's not widely used anymore in most dental offices, as we now take digital imaging as well. So dental radiography basics. First, the radiographic image is depicted by various shades of gray, black, and white areas. There are intraoral techniques for film exposures, and the first one is the bisecting technique. You're going to want to know this, as you will be doing this pretty well every day. So this technique is used to capture unique or very specific radiographs. The paralleling technique is also important to dental assistants, as it's the most commonly used technique for exposing the periapical and bite wing radiographs. We'll get more into what those two x-rays are in just a bit. But this technique requires that the film and the long axis of the teeth should be parallel. The x-ray beam is directed perpendicular to the line created by the teeth and film. The function of the film holder is to hold that x-ray film away from the lingual surface or inside surface of the teeth and parallel to the long axis of the teeth. So types of different film exposures, or the different types of x-rays more or less that you'll be taking, are as follows. Periapical radiographs, which are also known as PAs, they capture the entire tooth and the surrounding area. These radiographs can be used to assess the health of the teeth and the surrounding tissues. Bite wing x-rays, or bite wing radiographs, capture the crowns of the teeth, the interproximal spaces in the crest of the bone of both top and bottom teeth. These radiographs can detect caries, which is cavities, calculus, and measure the crestal bone height of the alveolar bone. Occlusal radiographs capture large areas of maxillary and mandibular arches. These can be used alone or supplement PA and bite wing x-rays. The full mouth radiographic survey is also called a FMX, and it's a typical adult series of x-rays, and it contains 18 total radiographs, 14 periapical and 4 bite wing radiographs. To take a quality x-ray, all desired teeth and surrounding areas should be captured on the film. All images are dimensionally accurate. Contacts are free of overlap, and teeth do not appear elongated or foreshortened. When taking a periapical x-ray, the entire tooth is visible on the radiograph, including 1 to 2 millimeters beyond the cusps and 4 to 6 millimeters beyond the apices of a tooth. The film should demonstrate the correct level of contrast to show very sharp detail of the teeth. It should not have streaks, spots, fingerprints, or any artifacts present on it as well. Some common x-ray or radiographic errors include distortion. The film is either bent or curved when placed in the mouth. That image will look distorted. Elongation. This is a common error when using the bisecting angle technique. It's a vertical angulation error, and it's caused by insignificant angulation of the cone during exposure. While you're doing the lab portion, it'll be good for you to actually practice taking these images and getting to see where sometimes things look elongated or foreshortened. Foreshortened is also a vertical angulation error. The opposite of elongation, it's caused by too much angulation of the cone during the exposure, and it's also caused during the bisecting angle technique. Overlapping is caused by incorrect horizontal angulation. This occurs when the cone is angled toward the mesial or distal surfaces of the tooth, and rather than at the interproximal areas. Cone cutting refers to the x-ray beam is actually missing a part of the film, and the shape of the cone being cut will depend on the shape of the cone itself, whether it is round or a rectangular cone head. Clear film occurs when the film was not exposed to any radiation, and the x-ray is then, the x-ray is in working order but is turned on. Double exposure occurs when the film is inadvertently exposed twice. A double exposure will occur. A blurred image occurs often when there is movement of either the patient or the tube head while the X-ray is being exposed. An underexposed film occurs when the image appears light or lacks contrast, and that's because those MAs or KVs need to be checked or adjusted. While an overexposed film, it occurs when the MAs or KVs or exposure time are also usually too high, and the film will look too dark, and it will be unable to see structures clearly on that image. A radio-opaque film means objects such as eyeglasses, earrings, partial dentures, or piercings can actually show up radio-opaque, which means very white, not transmitting light, and you will be able to see that actually on the X-ray image. The dental assistant should always make sure that all accessories, as the ones I just discussed, are actually removed prior to taking the X-ray. And sometimes you will have a backwards film. Placing the film in the mouth backwards can actually reverse the image, and it appears almost like a tire track on the image. So radiographic detail and quality is depicted by various shades of gray, black, and white on that X-ray. So the first word that you do need to know, and we've kind of discussed this previously, is radiolucent. So radiolucent means that dark areas on the radiograph where the photon penetrated open spaces or soft tissue reaching the X-ray film created dark shadows. So examples of things that might look radiolucent or darker on a film are as such: caries, porcelain, abscesses, cysts, soft tissue, and sinuses will actually be more of a darker levels of gray. Where radio-opaque means light areas on the radiograph or photons are blocked from reaching the X-ray film by dense structures. So such things that might be radio-opaque would be metallic restorations, bone, enamel, dentin, ortho wires or wires from braces, gutta percha, which you'll learn in root canals, and calculus or buildup of plaque on teeth can also look radio-opaque. So radiographic distortions can occur when the distance from the radiographic source to the object in the film X-ray can affect what the dentition or the definition of the magnification and cause distortion of that X-ray. So the definition is the overall sharpness of that radiographic image can change based on where that tube head is. So factors causing poor definition, as we discussed, are movement of the patient or tube head, and also the focal film distance. So the distance from the source of the photons, which is the tube head, to the image that's in the patient's mouth. A shorter distance, such as when an 8-inch positioning device is used, it can cause an enlarged image, whereas a longer distance, such as 16 inches, is used to give more of an accurate image. The object film distance, the distance between the tooth and the film, is also something that can cause poor definition. It is desirable to have the film as close as possible to the tooth. Enlargement of the image occurs when the distance is increased. So radiographic interpretation means the recognition and description of all radiographic images. Diagnosis is the determination of disease or condition that is causing the illness or symptom. As you can see, we diagnose based heavily off of what the radiographic interpretation is. So one thing that is seen on X-rays, and only X-rays, which our eyes can't see, is carious lesions. Radiographically, carious lesions present as a radiolucency, remember darker, due to the decreased density of tooth structure in the decayed areas. As we discussed, bite wing radiographs or bite wing X-rays are taken to aid the dentist in detecting these interproximal or between the teeth decay on posterior back teeth. With these types of X-rays, the apices of the teeth, the very top part of that root will not be visible, but the coronal portion of the teeth will be visible. Incipient interproximal carious lesions are types of lesions that are not at the advanced stage, so they are difficult to sometimes see, even radiographically. These lesions usually appear as very small triangular shaped areas just below the contact point and in the enamel or outer part of the tooth only. Moderate interproximal caries lesions are lesions that are in the enamel but extend more than halfway through the enamel to the DEJ or dentino-enamel junction. This appears as more of a triangular shaped lesion. Advanced interproximal caries lesions, those are past the DEJ, halfway between the DEJ now and the pulp. And then severe interproximal caries lesion means it has advanced past the DEJ and progressed more than halfway between the DEJ and the pulp. Restorations. So on images, we can see restorations or different filling materials, crowns, and things like that. So let's discuss a few of them now. Metallic restorations, the most widely known one is amalgam. It is the most widely restorative material used in dentistry, and they are most commonly used in the back teeth, and they produce a radio-opaque or more white image. Those are the silver fillings that you see when people open their mouths and you can see silver filling material on the back. That's an amalgam. Gold restorations are used for crowns, onlays, inlays, and bridges. You'll know more about those terms soon. But these restorations produce, again, a radio-opaque image. Stainless steel crowns are prefabricated crowns used a lot as a temporary type restoration or in kids. Since they are not as dense as gold or amalgam, they produce a radiographic image that is radio-opaque, but not as radio-opaque or white as gold or amalgam. Now let's discuss non-metallic restorations. Porcelain is one of the most commonly used ones in dentistry, and it is about the same density as the dentin, or middle part of the tooth, and it tends to have about the same radio-opaqueness as the dentin. Less radio-opaque, though, than amalgam and gold. We also use composite and acrylic restorations often, and composite appears radio-opaque but less than metallic or amalgam. And acrylic restorations appear almost completely radiolucent and sometimes can even resemble caries or cavities in an x-ray. Sometimes on images we can also see cements, which are used for temporary restorations or even as bases for deep restorations. They can appear more dense than dentin, but less dense than metal. The last one that can be seen on images also is gutta percha, which we'll discuss more during the root canal lecture. But it is a filling material used for endodontic procedures, and they appear radio-opaque in the radiographic image. So we will continue discussing more about radiation measurements. Once again, hang in there just because often different states require different levels of information, so we'll cover it all. And if your instructor determines that you don't need this portion, they can go ahead and move to the lab portion at this point. But radiation measurements, there are two different types of systems used to measure radiation. The first is traditional units, Roentgen's radiation absorbed dose, or RADS, and Roentgen equivalent man, which is REM. So SI units is another form, and that's per kilogram, gray, or sieverts. The properties of X-rays. X-rays are electromagnetic rays that are not detected by any other sense. They travel at the speed of light, and they have different wavelengths associated with them. So the measurement of rays are from the crest of the wave to the crest of another wave. There's amplitude, hard radiation, and soft radiation that is also part of those wavelengths. Amplitude is the vertical height from the top of the wave to the bottom. Biological effects of radiation is widely known, but we will talk about it more in depth now. Excessive exposure to X-rays or radiation can cause harmful effects to humans, as we all know. The negative effects often take years, though, to manifest themselves. This period of time is called the latent period. So acute radiation exposure means when an individual is exposed to a large amount of radiation in a very short period of time. Whereas chronic radiation means occurs small amounts of radiation over a long period of time. So genetic and somatic cells can be damaged from X-rays. So genetic cells include the reproductive cells, such as the sperm or ova, and damage to these cells is passed on to subsequent generations. Somatic cells can damage these cells, but it is not passed on to subsequent generations as well. So penetrating power is, it depends on various factors. So one is, as we said, the wavelength, but also the distance from it and the density of it. So X-ray generation is X-rays that are generated when matter is struck by electrons traveling at a very high speed of rate. And in order for this to happen, there has to be a source or a high voltage, acceleration, and a target. So the X-ray machine, as we discussed previously, but we'll go a little bit more in depth, has the power supply, which provides the power to heat that X-ray tube and the filament inside. There's a step down transformer and a step up transformer. There's also a timer, a control device that completes the circuit in the high voltage transformer and controls the amount of time that the tube head flows those currents to the X-rays. The filtration is there's a little aluminum disc that's placed over the opening of the tube head, and its purpose is to remove the low energy photons from the beam and decrease the patient's exposure. And then you have collimators that increase the film quality and help to also decrease the film exposure. So the visual image is a representation of the internal structures of an object that is placed within the path of the X-ray beam. The goal is to obtain maximum differentiation of the tissues in the developed radiograph. This differentiation is accomplished when the radiograph has distinct qualities. So the density, as we discussed, the radiographic density degree is the degree of darkness on that radiograph. And we can actually manipulate that density in a few ways. By varying the milliamperes, varying the kilovoltage peak setting, and the varying exposure times. So there are different ways to actually change the density. The radiographic contrast is the number of shades of gray that can be seen in an X-ray. And remember, we discussed there's going to be various levels of gray, white, and black on that image. So we can also change that by the short scale, the long scale, and other factors can also affect the contrast, such as the density of the object, the thickness of the object, and the quality of that X-ray beam. Film fog can occur when film exposure to light, radiation, or developing solution can have a poor quality to it. So there can be light fog, there can be radiation exposure when the film is actually in an unprotected area, or processing error as well. There can also be radiographic distortions, which we discussed, such as penumbra, umbra, and then other factors that include movement, as we said, of the patient or the tube head, different focal film distance, as we discussed, object film distance, and once again, as we discussed, the type of film. Magnifications, two factors affect the magnification, and that can be the focal film distance and the object film distance. Distortion occurs when the accuracy and the size or shape of the object is in the radiographic image. So the PID angulation is excessive angulation causes the image to be foreshortened, as we discussed, or an insufficient angulation occurs when the image appears elongated. So film processing errors include light film change, dark film change, fogged film, sometimes getting a partial image, and film artifacts. Film artifacts can be things such as water spots, fixer, developer, film not washed properly, or dark fingerprints. Now, most of these film artifacts were when we actually processed true film in a processor or with different dip tanks. This is not often the case anymore, as I said, because digital imaging is now being used. Same with the film packet, which you'll see in your notes. Film packets had an outer film, a little dental film, black paper, and lead foil to them. And we used to have to actually pull all of them apart, put the film in an actual processor, and use some of those different solutions to actually have the film be a true X-ray. Well, not anymore with digital films. It is important to know, though, as we move on, radiographic landmarks. So density of two structures, as we discussed before, are the enamel dentin and cementin those appear radio-opaque. Pulp chambers and root canals are more radiolucent. Alveolar processes in the mouth tend to look more radiopaque. So landmarks in the maxilla, the upper jaw, is formed by two maxillary processes. Each bone in the maxilla has little air filter cavities called sinuses in them. The maxillary molars have 3 roots. The maxillary premolars have 2 roots. So often, these different landmarks in the maxillary, if they are actual bone and roots, can look more radio-opaque, whereas the sinus will look more radiolucent. You'll also see in the images the nasal cavity, which will look radiolucent as the nasal fossa. The nasal cavity actually has different bones and septums, and even the lower border of the nasal cavity, which can have various levels of grays, being radiolucent all the way to radio-opaque. The incisive foramen, which is located, it is superimposed between the roots of teeth number 8 and 9, and it is more radiolucent. The median palatal suture, which is right down the middle of the palate, is radiolucent. The maxillary sinus, as we previously discussed, is actually more radiolucent, as it is an air-filled cavity. The zygomatic process, which you'll be able to sometimes see, is right here and is often radio-opaque because it is made more of bone. There's trabeculae and tuberosities, which we're going to get more in depth with later, but those tend to be more radio-opaque because they are made of bone. Now, landmarks in the mandible include the mental process, or mental ridge, which is once again made of bone, so it is more radio-opaque. You have the mental foramen, which is where nerves are actually located, so it's more radiolucent. You have the mandibular canal, which once again is where nerves lie, so it is more radiolucent. You have the external oblique ridge, made of bone, so it is radio-opaque. The internal oblique ridge, which is also made of bone and more radio-opaque. And then you have the mylohyoid ridge, which is also more of a bony area, so it is radio-opaque. Radiographic interpretations also include carious lesions of both the occlusal buccal, lingual, and root surfaces. So occlusal decay can be seen, and incipient occlusal decay, you cannot always see that actually on an image. Hazards of radiation. All radiation is potentially hazardous, but the degree of cell damage depends greatly upon the operator's safety techniques. Ionizing radiation affects live tissue by causing an imbalance in atoms and molecules. So the direct effect theory states that most cells do not sustain a significant amount of damage when interacting with the photons. However, when X-ray photons strike the DNA of a cell, direct injury is caused to the organism. The interaction causes immediate death of the cell or death at the time of cell division. The indirect effect theory states that ionizing radiation can give rise to free radicals, which can be harmful to different tissues of the body. So biology is actually the study of how radiation does affect different tissues. So what they found is there's radiosensitive cells and radioresistant cells. The radiosensitive cells include the cells of the ovary, testes, bone marrow, interstitial epithelium or intestinal epithelium, and skin. The radioresistant cells actually include glandular tissue, muscle, nerve, bone, and enamel. But the cumulative effects include repeated exposures to radiation, and they do find that it has a cumulative effect over time. So if you have repeated exposures over and over again, the risk of certain types of cancer or other diseases does increase. Well, you made it. You made it through all of lecture number 4, and hopefully you learned a few things. Please know that by the end of this, you're probably more confused than anything, but during your lab, you'll actually be able to process and look at these images and see all the different radiolucent and radio-opaque imaging. So thanks so much.